Welcome everyone to the Alberta Transplant Institute seminar today, April 3rd. First, we'd like to start with a land acknowledgement. We acknowledge that the University of Alberta is located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continue to enrich our vibrant community. We would also like to thank Paladin, Astellas, and AstraZeneca for their support of the ATI seminar series. Today's speaker is Dr. Sean Spence. Dr. Spence is an internist and intensivist at the Chinook Regional Hospital and the medical lead for the ICU. He also has a Master's of Science in Healthcare Quality from Queen's University and is the AHS South Zone Physician Lead for Integrated Quality Management. He is originally from Calgary, but has called Lethbridge home since 2019. When not working, Dr. Spence enjoys spending time with his 2 kids and fly fishing when time allows. His seminar title today is Organ and Tissue Donation in a Regional ICU, Pearls, Pitfalls, and Lived Experience. Dr. Spence, please take over.
Thank you very much, Carrie. So for those who I've not met, I'm Sean. I'm one of the intensivists down in the South Zone and also work as one of the SEND docs. And so through that role, organ and tissue donation has definitely become a large part of my practice, also something that I deal with as the unit lead. So I felt very fortunate to be asked to give this presentation today. Sorry, I'm just trying to get my slides to advance here. There we go. I will begin by saying that I do not have any conflicts of interest relevant to this talk being delivered. And I also don't really talk about any therapeutics, much less any therapeutics being used in an off-label manner. And the goals for today, I'd really like to highlight kind of the differences in our system's maturity and infrastructure as it pertains to this. I think that, there's an understandable natural tendency to focus on the larger kind of quaternary academic centers. I mean, it makes sense. It's where a lot of the organ procurement happens, and it's where a lot of the transplantation happens. But definitely regional sites do have a role to play. And I would say, especially since the advent of the SEND program, likely playing a larger role. Talk about some of the challenges and opportunities as it pertains to us doing this in our site. And then hopefully to meet some people and foster some connections so that we can share some insights and learnings and all do better as a provincial team. I'd also like to do a land acknowledgement that I am speaking to you folks from Lethbridge. And so in the interest of reconciliation and with the goal of actively fostering anti-racism, Lethbridge is located on the traditional meeting place of the Kainai and Piikani nations and home to the Métis Nation of Alberta Region 3. The Blackfoot people have much to teach us about wellness, including the focus on nature, rituals, and connection with others. And I'm certainly honored to work with the Blackfoot people to learn from them and learn about their traditional ways of knowing and healing. So this yellow square kind of shows my neck of the woods. I'm originally born and raised in Calgary and really didn't know a whole ton about Lethbridge until I moved here to take my first job, and it feels like time has flown ever since then. We've kind of got a east-west division to the zone, and so more or less where that orange square is sort of the Lethbridge catchment area. Claire's home kind of feeds up to Calgary, but really the main sites that we have are Lethbridge, all of the red dots, so Tabor, Raven, Cardston, Lundbrook, and Pincher, Blairmore and Pincher. They're all admitting facilities. The yellow dots in Coaldale, Fort Macleod, and Milk River are emergency departments, and so they will often refer patients to the other sites. And then that part on the map is actually that beautiful shot on the left, the St. Mary's River, where I've tried to go fishing and been skunked. And then looking around here, you can actually see that around Cardston, all the way up to Lethbridge, in fact, is the Blood Reserve, or the Kainai Nation. That's actually the single largest reserve in all of Canada, with about 14 to 15,000 people living there. And then nearby, smaller, but certainly equally a very large and beautiful place is the Piikani Reservation, closer to Brockett, and that has a population of about 4,000 to 5,000 people. With regards to our model of care at our local site, I actually got hired in Lethbridge as the first purpose-trained intensivist on the ground, and Tavish essentially got hired more or less the same time as me. That's Dr. Tavish Barnes. He was my chief resident, so a year ahead of me in training in Calgary. And so right around kind of October 2019, we went from a open model ICU, which yes, is old school, where virtually, anybody who admitted to the hospital could admit their patients there. Surgeons could do it, obs-gyn could do it, medicine could do it, in theory, hospitalists could do it, although typically by that point, internal was involved. And as it stands right now, we have a rotating pool of four of us, where one of the tranches is split between Doctors Aaron Lowe and Kurt Olson. And then every third week I'm on, every third week Dr. Barnes is on. We provide 24/7 intensivist coverage to our patients who are already admitted to the unit, meaning that daytime admissions are all handled by us. And then kind of Friday night, Saturday night, Sunday night, and sometimes Wednesday night after hours admissions are also handled by us. Previously, over the weekends, we'd also be responsible for internal medicine consultations and admissions, which is, it was very, very busy. And due to kind of local growth in the center, we're in fact kind of phasing that out because it literally got to points in time where there just wasn't enough time and wasn't enough ICU doc to go around. We also support our outreach teams, and then both Tavish and myself quite intentionally, in fact, split the FTE for the SEND doc because we're both interested in it. We both find it rewarding and good work. And we can talk a little bit more about the SEND program for those not already aware. But on top of that, there's virtually, both of us having young kiddos and living here in Lethbridge. If one of us is out of town, there's always another one in town. And so there's pretty reliable availability of somebody with know-how in neuroprognostication and organ donation. We've got fairly intermittent internal residents on with us from Calgary, and the same thing, we've actually set up a purpose-built family medicine resident R2 rotation within our unit with the interest of fostering in-zone relationships and helping retention. But certainly there's a lot of the time where we're it. And so not at all with the intent of making it seem like a contest, but certainly we're as busy as one of the A, B, or C pods at the foothills or the Rocky View or the South, but a lot of the time it truly is just the intensivist on. And so it can definitely be a lot of work to handle when you don't have an MP or a resident or a fellow to help you out with that. And so I think it's worth highlighting that, when we first started here and we first moved to an ICU, it in fact was a very, it was a big transition. We were moving from a place where a lot of the time doctors were not available during the day because they were in their own clinics. Obviously, everybody was working very hard and trying to provide the best care that they could within the constraints, but it was enormous and daunting, the conflicts of time and priorities that these docs would have. And so we first kind of moved to stabilize what was previously maybe an inherently unstable system. And in so doing, we now have our daily routine that is very much like that of any other ICU in a major center. So we have, multidisciplinary rounds where nurses will give a report. We have pharmacy present, we have RT present, we have the doc team present, we have family present. And so that was a very large shift there. And in so doing, we've now really started to standardize, how we conduct our rounds, how we give our reports. And in so doing, that has then kind of led us to move on to these other two, optimize and innovate, because I do think it's important to recognize that, when you're dealing in a very transplant-centered silo, which is amazing and fantastic, it's also worth noting that that's really far removed from the care delivered in other parts of the province. And, some of these units where they're having a hard time finding docs to cover or having a hard time finding enough nurses. I mean, obviously everybody wants to help and participate and help foster a culture of organ and tissue donation, but that also requires a certain level of organization and system maturity, which thankfully I think we're getting there, but is also something that can't necessarily be taken for granted at all of the sites or even all the ICUs within our province. And so with regards to optimization, that's where our participation in things like venting wisely to promote excellence in mechanical ventilation, or even a local QI initiative I did where I helped teach the RTs how to use ultrasound for art line insertion. There's definitely some, higher level stuff now happening to help really streamline and target the care that we're delivering. And then also, hopefully, the next steps being some, initiatives coming from our unit that might get disseminated province-wide. But it's definitely required kind of at least the first two steps of this journey being taken before we were anywhere even kind of near being ready to really pull our weight with regards to organ and tissue donation in Alberta. And so one of the first things that I also did when I came on was to really just come up with a standard set of criteria for, who can we safely keep in zone and close to home and in our ICU. We obviously want to keep people close to home and have a rich, diverse, and interesting practice. But at the same time, too, the last thing I want to do is to try and be the hero and keep somebody in my hospital who shouldn't be there. And so really what we did do is just make a clear line that, any neurosurgical cases, any neurosurgical emergencies that would obviously need to go to Calgary. The same thing would apply to cardiac surgical emergencies, vascular surgical emergencies, any level one traumas, or any STEMIs. And I guess the one consideration from this then is that, obviously the largest centers with regards to organ donors, both DCD and DNC, are going to be like the UAH and the Foothills hospitals. And, that's because they have those trauma, neurosurgical, cardiac surgical, CCU services. And so as a result of that, I mean, we still do actually have quite a bit of activity, as you'll see in subsequent slides. But because of the appropriate subselection of these patients going up to Calgary for the specialty services, a very large proportion of the patients that we're dealing with regards to being organ donors, either through DCD or DNC pathways, are people who are in our unit as a result of opioid overdoses and sequelae thereof. Even other things, where there isn't a neurologic injury currently, they are not included within the DCD pathway within the Calgary Department of Critical Care Medicine. And so really, this has really become, it's a big part of our practice, but a lot of it is kind of dealing with fallout of patients and families affected by the opioid epidemic. And so it's interesting to review, previously a lot of sick patients would be sent out of the zone, but we are definitely doing a good job of keeping critical care consults within the South Zone, both in Lethbridge as well as in Medicine Hat Regional Hospital, where they also now have a SENDoc, Dr. Jaime Bastos, who's fantastic. And so we're doing our best to keep people in zone closer to home and help build our critical care program. On top of that, if you look at it, a lot of the consults to CRH are either being admitted directly or being triaged in the emergency department, but of people that we're sending to Calgary, it's really much less common. And those are going to be cases where there are specialty surgical or mechanical circulatory support services required, or in fact, actually a large number of our transfers going up to Calgary now from our ICU, especially are patients who are being given an opportunity to participate in organ and tissue donation. And so, like anywhere, we are not devoid of challenges. Sure, there's been kind of the giant paradigm shift into moving to a closed ICU model. On top of that, we're actually also in the middle of a renovation where the old labor and delivery department that was immediately beside our unit, that kind of got spooled up as extra space during COVID. We're now starting to utilize some of those rooms, given that we're funded for 20 beds total, but we do have ongoing renovations. Room numbers are constantly changing. What rooms are open and what rooms are closed are always changing. And so certainly during busier times and with higher acuity patients, oftentimes patients like those who end up being eligible for organ and tissue donation, it can be a bit of a musical chairs game. The same as everywhere. We're very lean on staffing. Again, not wanting to play the violin, but I would say that what I didn't realize having trained in Calgary, but the staffing ratios even prior to the pandemic and attrition that brought on were extremely lean here. We're starting to catch up to Calgary, but even just trying to catch up to those ratios, it's often a challenge given the huge exodus of staff out of healthcare or to other provinces after the pandemic. On top of that, as we're seeing many other places, we're having a lot of new staff, which I think also can be viewed as an opportunity. But previously where somebody would have had to worked a certain number of years before being eligible to be an ICU nurse, we're hiring new grads now. Previously this was unprecedented. I think in many ways it's a positive because you have an enthusiastic, young, and coachable nurse, but it's also somebody who, there's something to be said for experience and hours spent awake doing stuff in the hospital after hours. And so that part needs to be built. And as a result, many will have also had less contact with organ and tissue donation as a result. Because we're an ICU and a CCU, at least co-located right now, we can be more kind of susceptible to large shifts in patient numbers, because not only if you're getting critically ill patients, but you're admitting all the myocardial infarctions, you can certainly have large and rapid fluctuation in patient numbers within the unit, which can have implications for staff, bed, ventilator availability to help care for patients who require the care required prior to organ and tissue donation. Same thing with right now, we're actually like blowing the wall out between the two areas of ICU. And so that will allow us to effectively be co-located, but prior to that, to spool up or make active that other area of the ICU, even if it was for a couple of patients, you'd need to commit 3 or 4 nurses to have safe redundancies and coverage. And so that has been certainly something we've struggled with to say, can we do this? Should we do this? Certainly the intermittent resident and tier 1 coverage, it can be tiring. There's definitely been times where you're up all night and then you're all day rounding. And then on top of that, you're going to be there late, doing a death by neurologic criteria examination. And so it can be taxing. It's definitely a labor of love, but it's something that we enjoy. And then also, as everywhere else is feeling, overcapacity and bed block pressures, limiting the availability of ICU beds, or the typical safety margin that we like to try and maintain for CHI guidelines, and the ability to help our emergency colleagues offload safely, quickly, and effectively. And so these are definitely all things that factor into patient flow and our decision of who, how, when to admit. And, given that patients requiring post-arrest care and the ones that typically are the patients who may progress to being eligible for organ and tissue donation, there's definitely pressures from these factors that may affect that. And then, of course, let's talk about the elephant in the room. The last, 3 years, there's been the pandemic. And so just when we were starting to get our new normal of a closed ICU and a multidisciplinary rounds, all of a sudden this, ginormous monkey wrench gets thrown into it. And thankfully, during the first couple waves, it really wasn't too busy. But after that, it was quite outstanding how crazy, busy, and often changing things were. And so, not only were beds extremely scarce, I think we got up to 24 patients admitted, 22 ventilated at one point in time for our previously sleepy little unit. But on top of that, as our knowledge of COVID changed and evolved, for a while there, and understandably, there were certainly kind of many hard stops to donation in COVID positive patients. And so during that point in time, there definitely were periods where there was a hard stop to much of organ and tissue donation activity out of an understandable abundance of caution. And so that really was a bit of a hiccup after we previously kind of got into a bit of a new normal. One of the things that's certainly worth commenting on, and especially I would say, it's probably underrepresents our center, because we're not a neurosurgical center, but really, year on year, there is a huge growth in the proportion of organ and tissue donors that are coming to that point as a result of the opioid crisis. And so that coupled with the that coupled with the fact that all of our neurosurgical patients or trauma patients are going to be appropriately transferred to Calgary really means that there's a huge intersection and a huge overlap between patients suffering from opioid use disorder and the patients who we ultimately end up admitting after a post-arrest in the community, who end up being those who donate organ and tissues. Also, I'll highlight that, unfortunately, when you look at the rate of overdoses in Lethbridge, we unfortunately also hit above our weight class. We are very much affected and have a very high rate per 100,000 person years. And so, we're a city of 100,000. Our catchment area for Lethbridge is about 300,000, but of that, certainly the amount of fallout we see from this, and as a result, the amount of organ and tissue donation activity that results from that is sizable. We also, again, hit above our weight class with regards to emergency room presentations and admissions for opioid use and sequelae thereof. And so, not only are we busy as people kind of seeing that most severe end for people who've had an arrest and likely have a hypoxemic ischemic brain injury, but on top of that, it's a significant and ongoing source of demand for care in an already busy hospital and emergency department. Part of this that has also kind of changed is that, I actually live quite close to the hospital of time that I can get to the bedside in ICU in less than 8 minutes if it's really bad. But I didn't realize until kind of doing the dig for this just how well attended our previous safe consumption site was. Now, this was the Arches site, which unfortunately has closed as a result of kind of concerns over proper financial management. But I mean, look at the cumulative total of that gray line. Look at the number of visits per quarter per site. That's a very large number of visits, and certainly, anecdotally, which is not the highest level of evidence, but for a period in time when the new normal was being established, following the closure of Arches, we definitely saw a large uptick in people who were overdosing and ending up in hospital who may have otherwise not needed that, given the services that were available. And on top of that, not only did we have a very high amount of activity there, but even when standardizing for the amount of activity, the rate of actual overdoses requiring medical intervention is quite high. On top of that, another kind of layer to the complexities of the social determinants of health, and all of this contributing to our donation activity, is the fact that unfortunately the rate of opioid poisoning deaths among Indigenous patients is significantly and appreciably higher than that among non-Indigenous patients. And as we previously discussed, we have a very large population of Indigenous patients in our zone. And so as a result of that, we also see a very large overrepresentation of Indigenous people among those who have had an overdose severe enough to lead to the question of hypoxemic ischemic brain injury, and possibly being somebody who could be an organ and tissue donor. And again, just seeing that over time, unfortunately, this is a trend that has not yet peaked, and is certainly humbling when you look at it with regards to these numbers. And so as a result of that, the Pecani Reserve over in Rocket, just shortly into the new year, actually announced a state of emergency because of a very large number of overdoses in a very small amount of time. And this is ongoing, but obviously, a similarly severe case can be seen with regards to the Kainai Reservation. And on top of this, it's truly heartbreaking to see the number of times where I recognize family members, because I've cared for multiple of their loved ones who have had an overdose and who have had, an unsurvivable catastrophic brain injury as a result of that. And so you're already starting with, numerically relatively small and tight-knit communities, but then just with how prevalent this is, you're seeing entire families being ravaged by opioid use disorder, sometimes entire families passing away from this. And it's always nice to connect with patients and families, but it's never nice when you're caring for, a subsequent loved one who has then suffered an opioid overdose and is now admitted under your care in the ICU. Furthermore, as a zone and as a city, I mean, kind of earlier this year or late last year, it was thought that about kind of 40% of our population within Lethbridge was without a family physician. And so because of that, you have people who, don't talk about healthcare matters regularly, don't necessarily talk about whether they'd want to be a donor, don't talk about things like advanced illness planning and goals of care. And as a result, may also have unscreened cancers or undermanaged chronic health conditions, certainly exacerbated by COVID and all the shutdowns. But as a result, oftentimes, when people are coming into ICU and being admitted, regardless of the reason, there's been a relative paucity of medical contact, workup, and management. And that can lead to many different competing issues coming to the surface in a relatively short amount of time. And so I think what this ultimately translates into for our unit is certainly there's a relatively limited distribution pathway of drugs into Southern Alberta. This isn't a talk on policing, law enforcement, et cetera, but you can definitely tell when a bad batch is in the area, because sometimes you'll go weeks without any, and there's been afternoons where literally we've had like 4 post-arrest people admitted. And so there can definitely be a very big ebb and flow to the admission rate of donation eligible patients to our ICU. And sometimes, when it happens all at once, it can be very difficult or stressful, or there might not be the manpower either in our unit or in Calgary to accommodate multiple people who have overdosed and have an unsurvivable brain injury and are therefore willing or wanting to proceed down a organ and tissue donation pathway. Um, Sometimes it can also be quite challenging to neuroprognosticate. I think we're very lucky in that, there's always a send doc around. We're never more than a text away. We're all pretty close colleagues and have no shame about bugging the other person to come in and help take a peek. And we're also very lucky that our radiology colleagues tend to be very supportive. And it's very, very rare that we ever have a hard time getting an MRI or a CT or even a nuclear medicine perfusion scan. But on the flip side, if there are cases where you're worried about non-convulsive status epilepticus or other things that may be confounding rendering proper neuroprognosis, we have a single EEG tech for the entire city. And on top of that, she is getting closer to retirement. And so definitely there's been some bribery with snacks and eventually after hours pay that we've worked out with her department in order to be able to get that support. But it can certainly be, there's times where we don't have any EEG availability in our city of 100,000 people because how dare the one EEG tech actually take some vacation time, which I mean, she's obviously entitled to. So that is certainly a resource constraint, but we are, as a critical care community, looking at some potential workarounds with regards to maybe more user-friendly and point of care EEG type things. Little patient contact with healthcare practitioners. And so, as a result, patient and or family health literacy may be decreased. There may be cancers that are presenting during their initial presentation because they've not been screened and they've not had a regular physician contact. And so certainly there can be, as a result of that, it's that much more foreign having to interact with us, never mind in the ICU setting, which is daunting for anybody. But on top of that, there's been minimal out of hospital contact before then. The tough part and the part where I hope that we can make a difference and aim to really strive to be excellent is that, we're dealing with patients and families who are dealing with the loss of loved ones very, very frequently as a result of opioid use disorder and an inadvertent overdose. And so, oftentimes the patients themselves are homeless or partially housed. Their family members may be in a similarly socially tenuous situation. Um, Oftentimes these are families who have lost more than one member or friends. And so, it's obviously we want to do our duty and offer organ and tissue donation to all eligible patients. It's now the law since the passage of Bill 205, but also making sure that we're really striving to be empathetic and genuine because the degree of adversity and sadness that many of these patients' family members have seen, I don't know if I'd be able to function through it. And so they're really dealing with a lot, and we try to support as much as we can. On top of that, we can talk about it a little bit differently, but there's some interesting Canadian research by Singh et al. Out of Toronto, where, based on the evidence, people with traditional Indigenous beliefs are less likely to consent to organ and tissue donation. And so we'll talk about the implications of that in a few slides. And so on many hands, you can look and say that there are a number of things here that are tough and stacked against, doing a good job of this or conducting it well. But I think that also based on how we look at this and based on how we frame things, there can certainly be some opportunities to do a lot of good and help not only, with regards to promoting progress, growth, and excellence in organ and tissue donation in Southern Alberta, but on top of that, helping take care of families of people who have died as a result of the opioid epidemic and maybe helping foster greater trust in healthcare and better relationships as a result of that. And so why is there a picture of Paul Stanley and Gene Simmons? Well, at the end of the day, you got to keep it simple. And so stick to first principles. And really, that's kind of the bottom line of what we do is that number one, with organ and tissue donation, especially through, the southern half of the province where a severe and non-survivable brain injury is a requisite within the current paradigm, we need to make darn sure that we're rendering a proper and diligent neuroprognosis. And so that's where having the SEND docs available, that's where having our colleagues from neurocritical care in Calgary available. You never ever want to paint a grimmer picture than is the case. And so we strive to very much, be guarded, cautious, and evidence-based when giving our neurologic prognoses and in adhering to best tests and best medical evidence, not only for when we're neuroprognosticating, but also in taking care of the post-arrest patient. We want to give that patient every possible chance at neurologic salvage after an out of hospital cardiac arrest. And so we absolutely do everything that we can to manage to target temperature, to treat MAP, manage sugar, all of those things, so that, hope for the best and give a post-arrest patient a chance at a good neurologic outcome. But if the picture is starting to look more grim, also making sure that we're very diligent and regimented in how we go about, prognosticating that patient's neurologic picture. Uh, the same would go with regards to communication. So I would say on one side, not having residents and medical learners. I mean, it's getting to be more and more frequent, and we very much like having them. And so spread the word that we're a fun rotation. But sometimes being the main quote unquote spokesperson for critical care, having contact with that patient and the family, it is a nice opportunity because it allows you to have multiple sequential interactions with them. It tends to help build a rapport, build trust, and it often it helps avoid mixed messages too, because it's amazing in larger centers where you have, a junior resident, senior resident, fellow staff, maybe different staff the next day. Certainly there can be some changes in the message. Obviously, nobody doing it with ill intent, but we have a pretty unique and nice opportunity for longitudinal contact with patients and families. And I think that can be very helpful in helping work through and navigate what is a very difficult time for everybody involved. Also focusing on patients' values and wishes, really trying to put it in terms of, if your loved one could talk to us right now, what would they tell us? Or if you've not explicitly had this conversation with them, knowing them as a person, what do you think that they would want? And also, keeping in mind, who that person is, where they've come from, where they've been through, what their beliefs are, both, morally as well as spiritually or religiously. It's important to keep that in mind, because I think that for many Indigenous patients and families, not donating is very congruent and aligned with that traditional belief system, and that's something that needs to be respected and honored, rather than looked at something that is, a negative or a problem to be overcome. And I think honestly, at the end of the day, the biggest thing that we try to do is to just be kind, compassionate, and authentic. I think sometimes all of us in critical care, we realize, it's our job. We come there, our friends work there. It can be easy to have quite a bit of levity to it, but for our patients and our families, they're there because them or their loved ones are having a terrible time. And so, just realizing the impact that can be had by, being kind and compassionate and just giving time to talk and help share the experience with them can be huge. And whether or not it becomes manifest in higher rates of consent doesn't really matter. At the end of the day, we need to be able to take really good care of our patients and their families. And so one of the things that kind of helped spur, I think, province-wide was Bill 205, where it now is mandatory referral patient province-wide. And I think that was a helpful reminder, but not only just for us docs, but now, nurses and RTs as well, because they're, inextricably linked to our delivery of critical care. They're very large parts of our team. And so having people know that this is the law, having people know that they should be, empowered and encouraged to speak up. Certainly, if everybody understands what organ and tissue donation is, how it works, the various pathways to it, the more people that you have that understand that and get that, then if somebody's tired one day and forgets to bring it up or address it adequately, you've now got 2 or 3 other people who are very smart, very qualified, and can act as redundancies to help bring that up and minimize the miss rate. And we've found these flow charts very helpful. I think I printed them off and posted them up as soon as Bill 205 got posted, because again, there's just so many moving parts. But when you have a nice, easy, followable algorithm like this, it doesn't really take more than a minute or two. And that way you can make sure that you're not, depriving a patient or a family of the opportunity to potentially help others through organ and tissue donation. But on top of that, it helps save a little bit of cognitive load when you're dealing with many other sick patients or many other competing issues within that same sick patient. And I will apologize to the HOPE coordinators. I would rather overcall and be turned down than not call. But this is just a great way to, keep it simple, keep it checklist and guideline based, and make sure that we're doing our best possible job to not miss referrals. And one of the books that I encountered during my quality improvement masters was the 4 disciplines of execution. And I think it's a really good, it shows this very well. And I'll do a disclosure. I've not been bribed at all by the SEND program to sing their praise. I just think they've organically done a really good job of this. I mean, at the end of the day, we all have our whirlwinds, right? We all have the core aspects of our clinical practice that are busy, that take up a lot of our time. And a lot of the time you're running from fire to fire, running from deteriorating patient to deteriorating patient. That's a huge amount of our mental bandwidth and our time. But if we focus on exclusively that, we're never going to advance quality. We're never going to advance safety. Or in this case, we're never going to advance, rates of organ and tissue donation. And so, by helping us focus on a few key metrics that regularly get audited, and by showing us these lead measures, especially as it pertains to approach rate and consent rate, it's been able to make a huge difference to us. And then on top of that, as you'll see, they make very user-friendly, compelling scoreboards that are regularly distributed to us docs. And in having us send docs look at charts, review them, both with regards to potentially missed opportunities, as well as to look at quality of documentation around organ and tissue donation, there is an accountability. And so, there are times where there have been misses. We're not perfect. No site is perfect. But, having that be identified and then having an informal but serious conversation with the person who is taking care of that has allowed us to definitely mark and then learn from and improve as a result of our missed cases. And so, as mentioned before, there are different social and religious and spiritual factors that factor into organ and tissue donation. And depending on where you live in the country, it's going to be variable. But for us, because of the social determinants of health and unfortunate inequities previously reviewed, a very, very large proportion of people in whom we're taking post-arrest care and or discussing organ and tissue donation are Indigenous patients. And we need to keep in mind that based on the belief system of many of those patients and their families, that organ and tissue donation is not something that's regularly brought up. And so twofold. Number one, I mean, I think that the way that Andreas and the SEND program do it is very respectful. The real measure of success is not the actual consent rate. We would like a high consent rate, but I think it's really the approach rate that is the most important process or lead measure. Because at the end of the day, people are free and should be free to make their own decisions. And our goal is not to convince or coerce. Our goal is simply to make sure that that opportunity is offered. And then on top of that, there are modifiable factors. If we can focus on having a good rapport with the family, on communicating clearly, on having face-to-face meetings, on having frequent meetings, certainly those are all things that may help increase the consent rate. But the goal is never to be in 100% consent rate or to convince people. The goal is to provide, excellent post-arrest care, excellent evidence-based neuroprognostication, and then to give people the opportunity to ask questions and decide as to whether or not their loved one would like to proceed as an organ and tissue donor. And so looking at our last year's kind of scorecard, again, as I've said before, this is, simple and user-friendly and useful for me to look at and to be able to glean a lot of information. Where looking at the screen charts, there were a total of 20, which may have totally been eligible, 12 in whom there was actual death by neurologic criteria diagnosed, two in whom it was suspected but not confirmed, and 6 in whom it was not suspected, not confirmed, but they still had a catastrophic brain injury. And so the referral rate, again, I would think it got better since Bill 205 being passed. And again, part of it may be that if the family doesn't consent, the ODO may not have been contacted, though we've now kind of just made it a matter of principle to just reach out and close the loop so that they know that we're thinking about this. But one of the things that I'm really proud of is our approach rate where, while not perfect, we're certainly, not lackluster with regards to approaching families in whom their loved one may be eligible for organ and tissue donation. And so over the last year, there's been a total of 2 missed opportunities, but there have been 6 opportunities where the donors have been referred. And as a result of that, there's been 23 organs transplanted. And so again, looking at miss rates, this is where I would ideally like it to be golf and have the lowest score possible. And looking back at historical data, again, 2022, some of that may have had to do with COVID, but we're certainly getting a lot better with our approach and referral rates. And I think that a lot of that has to do with the SEND program helping support us to stay up to date with latest guidelines, but also by offering kind of a community practice for support. And then, anecdotally, I think we're actually doing kind of a retrospective chart dive right now, but I think before the ICU was closed, certainly probably didn't have quite as many overdoses, but I think it was very, very rare that we would have organ donors referred from Lethbridge to Calgary. I'm happy to defer to people in Calgary with regards to that. But I think even since just moving to a closed unit and having people with, the dedicated training in that regard, it's been very helpful to, start identifying this as something important that we can do in cases where a good neurologic outcome isn't necessarily possible, and has allowed us to focus on this as an important outcome measure and goal, towards which we've been able to make some forward progress. And so, I mean, at the end of the day, having that cohesive team model is key, both within the docs. If we all feel comfortable and able to talk to each other about, coulda, woulda, shouldas, things that, hey, Sean, I think that you could have documented this better, or I think you may have maybe missed an eligible donor. And the same would apply between nursing staff and ERTs. And so really the ability to have multiple layers of feedback, but also multiple sets of eyes who can say, hey, have we considered organ and tissue donation? That's certainly a very large asset. The same would apply to creative problem solving. We really try to avoid having the word no in our vocabulary, and it's amazing, the number of times we've been able to adjust and manage things either due to staff availability or room availability to make sure that organ and tissue donation opportunities aren't missed or glossed over. The ability of our staff to take input and to learn from that, both physicians, but also our newer nurses, as well as our RTs. And just by virtue of, seeing more, doing more, you get better at this. And so it's definitely something that is now part of our regular practice. And I would argue as a result of that is starting to become part of our unit culture, which is key because we're proud of the work that we do in this. We very much appreciate the letters that we get from the Organ and Tissue Donation Agency about, cases where donation has been possible and the people that have been helped. And so helping do that, not only do we find it fulfilling, but I also think helps protect against burnout and overworked post-pandemic staff. And so, I think that it's positive for us as well. And so the SEND program, I really can't say enough good things about it. It helps me stay up to date with best evidence. We've got SEND ground rounds, we've got our meetings. On top of that, the close relationships that come with that, I know that I can always, if I'm scratching my head about something a little complicated, that I always feel safe to call Andreas or Julie or Philippe. And if anything, they're colleagues, but they're also friends. And so it's something that I legitimately enjoy doing, not only for the help to patient care, but also the learning and support that I know that I'm going to get. And hopefully that the same applies vice versa, where they, having trained half of the ICU docs who now practice in Lethbridge, Calgary is confident in the care being rendered and that we're known entities, and that, there's a high degree of interchangeability as a result of that. We're starting to see common situations where we're optimizing our own workflows. We have a death by neurologic criteria patient who now needs to go up to Calgary. We're starting to sort out more organically who to call when, because sometimes it's like, well, do I call the SEND doc here? Do I call the SEND doc there? Do I call the doc on here? Do I call the coordinator? And so there's definitely some organic evolution and streamlining happening to some of these common workflows. And as I said, both provincially, but especially locally, we talk about this more, we think about this more, and it's not a foreign, odd, or taboo concept. It's something that we can help make a positive difference, even in cases where a patient potentially has a non-survivable neurologic injury, or has perhaps even progressed to death by neurologic criteria. And finally, just having a team that you can trust, having people that back each other up, both, between Calgary and here, as well as at our own site. It truly is one of those, it takes a village to help facilitate organ donation, but we're very lucky that we have that village. And so we've got a lot of very smart, able, and supportive people. And as a result of that, I'm proud for, to see the growth that will be even better demonstrated after the historical review, but to see that, while certainly more room for improvement, we're also not lackluster in our performance, and we're doing quite a good job. And so talking lots, I think, is key. Remember that these regional sites are growing. There's a lot of expertise there. Some of these regional sites, I think a colleague of mine from med school, who's a neurocritical care specialist, is even in Red Deer now. So there's a lot of expertise and ability starting to proliferate at more regional sites. Talk about cases where we could have done better. To always think outside the box about new and different ways that we can maybe approach some of these workflows. And by standing up and working together as an organ donation community provincially, that's really how we're going to have the biggest voice and the ability to make the greatest impact. And with that, I will open the floor to our moderators, questions, etc.
Really good presentation. Just checking to see if anybody can either raise their hands or put any questions in the chat. I do have one question myself to get you started, and that would be, from your description of where you've been and your history and where I see where Medicine Hat is, do you feel like you have a lot to offer them in terms of advice and how to bring the program along?
I would say yes and no. I mean, I think that they're lucky that they've now become a closed ICU there as well. There's certainly times where we've had to share kind of insights on admission criteria, transfer criteria. Sometimes we need to take their patients if they're needing pacemaker implantation here in Lethbridge or CRRT, which is not a modality offered there. But at the same time, too, by Jaime, by virtue of having worked a lot in Calgary and trained there, and by virtue of belonging to the SEND group, I mean, they're already doing a very capable job. I think they've already had their first organ donor referred and who has donated. And so, I mean, we're here and we're happy to offer the advice if needed, but they're already making leaps and bounds on their own and functioning very highly. And so we're there as a sounding board or to offer a pair of hands if needed, but they're already doing a fantastic job in that regard. And it's really cool that first ever organ donation case just happened recently. Like that's awesome. That's a huge milestone.
Yes, do we have any other questions for Dr. Spence?
Yeah, I really appreciated the slide showing the consent rates based on different spirituality or ethnicity, and just think that it's important to point out, I agree with you that it's important to take a very compassionate and individualistic approach with each family, because if you look at that chart, you can see that the rate of consent for Aboriginal spirituality is the same as the rate of consent for Christian Orthodox. So it's important for staff not to make assumptions and not to think of Aboriginal spirituality as a monolith, very different even in the northern and southern halves of Alberta, and different for every community and different for every family. So I appreciate the perspective that you take in terms of really addressing each family individually and always offering the option.
Thank you. And I mean, on top of that too, there are many families where, their overall belief system is an amalgam of more kind of Catholic or Christian beliefs and traditional beliefs. And so, it's absolutely as far as you can get from one size fits all. And then on top of that, there's been cases where I've literally had people say, previously I wouldn't consider this, but I now know somebody who has been kept alive as a result of transplanted organs. And so as a result of that, I'm amending my beliefs on this and actually want to have my loved one be a donor. And so it's something I honestly think is not discussed very much, if at all, within these communities, just because of huge and other pressing issues. But it's also really cool that, the IWC, the Indigenous Wellness Corps, is looking at ways to help socialize organ and tissue donation within Indigenous communities so that it's A, less of a shock, B, it's less foreign, and then also being able to offer, materials presented in a culturally appropriate and oftentimes even in the Blackfoot language, so that people are able to make as informed decisions as possible.
Okay, thank you. Linda. Linda Powell.
Thank you. Yeah, just had to go off mute. Terrific presentation. Thank you, Dr. Spence. Are there opportunities evolving to be able to reach out to other diverse communities to normalize the concept of organ donation, language, cultures, etc.? And certainly approaching the Indigenous populations is a huge component, but there are other cultures as well. And how are we approaching that?
Yeah, and that's a fantastic question. I guess I will start by saying, kind of I'm most focused on kind of I'm most focused on my whirlwind. And so as a result of the patients that I take care of, the most contact that I have had is with communities from the Kainai and Piikani reservations. And so there's been fewer patients from other groups that I've encountered. And so as a result of that, I mean, I don't think that I would have the best insight. I really do think that reaching out and working with these communities should happen organically and should be led by people within these communities. And so certainly I think that if you're at a site where there's, patients of a certain background that you're seeing frequently, a lot of the time just getting to know families or getting to know loved ones, it's amazing how much of how oftentimes organic opportunities come up. And that's sort of exactly what's happened here, where in caring for mutual patients, I've been able to get to know some of the physicians. So Dr. Tailfeathers from the Kainai Reservation, Dr. Lena Potts from the Piikani Reservation, people from the school boards, and then was even recently out there acting as a panelist for the school board's family day, talking about the opioid crisis. And so I honestly think that those are the best sorts of connections, because by meeting people and by having them see, that you do care and that your heart is in the right place, that it can lead to very powerful allyship and cooperation. And then as a result of that, it's amazing the ideas that I've heard from people within these communities for helping do this. And so I think the same would apply anywhere, really, just getting to, identify a target audience, because I totally agree there's going to be other target audiences. And then having people from that target audience help, come up with a patient and family informed, culturally appropriate way to respectfully and impactfully engage with that patient population.
Thank you.
I had a question, Sean. It's been 20 years since I worked at the Red Deer Regional Hospital, but back then, ground transport and air ambulance was almost non-existent for organ donation at that time. But how much does transportation, maybe this is half a question for Carrie too, because you've been on the opposite end of the exact same transaction, but how much does ground transport, weather, air ambulance and things like that become a factor in proceeding with a donation, even if you have a successful approach with a family?
Thankfully, I would say very little. I do not any hesitancy or unwillingness to use more resource intensive transport modalities for either DCD or DNC donation patients. We do know, part of the work being done with the SEND program is looking at why people haven't consented. And usually if not wanting the patient to be sustained by artificial means for a long time is the case, usually that makes it kind of a non-start. I've yet to see it myself where that, maybe a 1 day or a 12-hour delay in transport has led to a family withdrawing consent for transport. Sometimes, especially if you're going to south or depending on, where other things are deployed, ground transport can be used. And oftentimes that's very appropriate, because by virtue of being suitable donation candidate, there's a degree of physiologic stability that needs to be there. But the support we get from Rapid and the STARS docs is great. And it's very, very uncommon that there's much, if any, hiccups that we have to encounter.
That's fantastic.
Okay, do we have any other questions in the last couple of minutes here? Oh, okay, well, again, thank you very much, Dr. Spence, for a wonderful presentation that was obviously well received by all.